No problem.
And camera's rolling. And go for it.
All right, Jean, can you tell me what your role is in the DaVita Village?
I've worked for DaVita since it was before DaVita, and I'm currently working in home dialysis, doing both home hemo and home peritoneal dialysis.
Great. And so,
Try not to shift so much.
Sorry,
Sway back and forth. It's okay.
was I swaying?
Just a bit, just a little bit. That's okay though.
you want to do it again?
I think that one was okay.
Okay.
So you can move on to the next one. Go for it.
So, what were your thoughts about the first presentation so far?
I found the first presentation really interesting. I've been doing dialysis a long time, as I mentioned, and I actually learned some things that I did not realize, particularly about the thrombolytics for catheters and the maturation for new fistulas, that they mature at about 6 weeks, and that's when they're mature. And if they're not mature by then we need to look at it. It's been very, very informative so far.
Great. Can you tell me briefly why you came to today's event, what you were looking to learn or to gain from today's event?
Well, I know that there have been some new innovations in dialysis access, particularly hemo access, and how they look at them and how the access is treated if it's not functioning as optimally as we would hope. And I was hoping to learn what some of those things were, and so far I have.
Great. I think we're good. All right. That was pretty painless.
Camera's rolling. Go ahead.
Brad, describe for me your role in Lifeline.
I'm the Regional Operations Director for Texas, Colorado, Kansas, and Oklahoma.
Great. And how long have you been with Lifeline?
I've been with Lifeline just over 2 years, with DaVita since before it was DaVita.
Great. I'm sorry.
What's the emergency? Go for it.
So, talk about the role you think that education, outreach, these kinds of programs play for Lifeline and the clients and patients.
The role that education that Lifeline does for DaVita and all the other dialysis centers that we service is huge. We partner with the dialysis centers, with the education coordinators, with the operations folks, and really help them and their teams get a better understanding of what it means to use an access center, what the advantages are, how beneficial it can be for their patients, for a variety of reasons, for reduce their catheters, to speed up the process, just to have dedicated people that care about dialysis patients instead of like a hospital setting. All of our guys in the access centers work with dialysis patients on a daily basis, so we understand the whole patient. We understand how important the role of access plays. So when we partner with them on educating them, it really brings it all together for them. It helps them understand how we can benefit the centers, but most importantly the patients.
Very good.
When the blood swings around and enters the venous circulation, it's under much less pressure, okay? So it's not meant to handle the high blood flow coming out of a fistula or a graft. And so that pressure, that shear force, causes the intimal hyperplasia, causes that vein lining to thicken, and you end up with a narrowing on the inside. Other areas will have central vein disease. So although that's not the immediate access, it affects how well the access runs. Okay? And last but not least is just stenosis inside the body of the access. Just from repeated cannulations, you get scarring related to that. Okay, up the outside with a ciliate vein coming up the inside. So a radial or brachiocephalic fistula, radiocephalic, brachiocephalic coming up and around. Those are the people with the bump and the dip in the new fistulas, and you've all seen those. You know, we typically don't react until they get to be like doorknob size. Then it's like, oh my God, how did that happen? You know, what are we supposed to do with this? The brachiobasilic or any transposed fistula actually has two swing sites. Okay? You have the vein that's swung over to hook onto the artery, and make sure, number one, you know which is the arterial, which is the venous anastomosis, but you want to pay particular attention there. Okay? Thrombosis is simply the formation of a blood clot inside a fistula or a graft that completely obstructs blood flow. With the stenosis, we have reduced blood flow. With the thrombosis, there's no blood flow. Your signs and symptoms are obvious: no palpable brewing, no audible, or no palpable thrill or audible brewing. If we stick it, you know, you get that real dark blood. Oftentimes, whenever you're feeling it, if you're feeling it right at the arterial anastomosis, you swirling in there, it can clot. So if you're sticking an aneurysm and pulling clots, you probably are. It's probably the clot that's lining the aneurysm, pseudoaneurysm. It's not that the access is clotted. Does that make sense? So as we look at thrombosis, you have a normal lumen that's narrowed, indicating that there's a stenosis there. And then as it's clotted, there's no flow through there. Okay. So you send your patients to us, and we're going to bring them in the room, and what we're going to do is cannulate them going in. Principal causes for thrombosis, again, are the unrecognized or untreated stenosis. Excessive post-dialysis pressure. Putting clamps on someone and then taping the clamp down, because if you don't tape the clamp down, they're going to bleed. That's a big warning sign. And we've done that. I was in dialysis a whole lot of years, and I need you guys to actually look at the screen, because otherwise you're kind of hampered a little bit. So grab a bag, because you're very bright. You have toys in there. Okay. Okay, my detectives, please look at the screen and you can confer amongst yourselves. All right, we're testing our critical thinking skills. We're looking for evidence, and we're coming up with conclusions. All right, detectives, what's our problem here? Aneurysms. Yeah. Somebody be the speaker. Okay, you can rotate that duty. I'll give it Democratic. We're in the access. So we're going to do a good access exam. And as John will teach us, we want to make sure that these aneurysms aren't really pulsatile, that they've got a normal thrill, normal brewing in the access. So we're checking for stenosis, and we're going to move our needle sites. Exactly. Thank you. You're not done. All right, detectives. What do we see on this one? What's this telling us?
Poor infection control with clean access, which resulted in an infection. A lot of skin erosion. So we're using the one side.
Right. Jewelry. Okay, we're in a bad place here. What do we want to do? What do you think we need to do?
Proper cleaning techniques before we even gently decide.
Well, how about if we stay away from them altogether? Yeah, because those scabs, those are the patients that come in, and whenever you take their bandage off, because they never take them off, space there is between the vein or the graft itself and the skin surface, because as it gets closer and closer to the skin surface, those are the ones that are most likely to erupt. Okay? Or I may send them right to the surgeon if my nephrologist thinks this patient is really in danger, and might send them right to the surgeon to say, what can you do about this? Look like to you guys. Collaterals, right. Collaterals.
Collaterals.
exactly. There's no critical thinking skills going on here. There's no critical thinking skills. We look at this patient and it's kind of like an insidious thing. It's, yeah. Exactly. So that's someone that you would send out saying, arm swelling, we suspect central vein stenosis. Exactly. Now the thing with central vein stenosis is that it always comes back. It's a year out of an angioplasty, that's good. With central vein stenosis, it's typically 3 months or less. So as soon as the swelling starts, or as soon as the veins start to come up, that patient probably needs to go back. Because those are the patients that are bleeding for 35 minutes and then get to the car and have to go back because they're still bleeding, or the ones that you have to send out to get a suture. See in our data trends.
Increased venous pressures.
Okay, so what does that mean? Inflow, outflow?
Bleeding time,
Right.
QTV went down.
What else do you see, detective? Detective in pink.
The URR, which is your KTV, it went down, bleeding time increased, the intra-access blood flow decreased, pump speed decreased, so,
Yeah.
and your venous and your arterial not showing up.
But the thing about all of these changes is they're not horrific.
Everything's going well, and hopefully that a really good line of communication, so you're getting that feedback, you're getting those reports to let you know that. That was one of my frustrations when I worked in the dialysis center. Like I said earlier, I would send the patient for evaluation and I would procedure, and then if the intervention was successful, of course the patient would go back for additional monitoring of the maturation process. But at this point, what I want you to understand is we never hesitate to refer the patient to a surgeon when appropriate. Okay? So we are an outpatient center and we are not an in-hospital center, and there are cases where, and I think for some of us we just kind of got stuck in the old, we do things one way and it's very difficult to shift and to change. That's human nature. And boy, did I learn that quickly when I went into education, because I was all gung-ho and I was like, oh, this is going to be great. I'm going to educate people. Everybody loves to learn, right? Oh, yeah. Well, then I got the people that said, clarify that, because I just had a question from somebody related to tourniquet use with fistulas. When we say use a tourniquet, it doesn't mean take a rubber tourniquet such as this and and use an incredible amount of pressure. Look at that. Oh, that was a lot of pressure, right? Like Superwoman. You don't want to use so much pressure when you wrap it around the arm that you're actually doing damage or occluding the flow. So it can be as simple as a finger or a hand or the patient's hand there.
Actually,
you want very light pressure.
In Denver area, our policy changed. Digital pressure is no longer allowed. Tourniquet only.
In the Denver area, or that's a DaVita policy?
It's a DaVita policy, but I don't know if it's Denver area only. I do know that in Sundance, it states it must be tourniquet.
Okay, but then that would probably be a DaVita